Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the fern.org website or on our YouTube fern.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. Our dizziness history. An overview of the dizziness history is important because knowing if the patient is describing lightheadedness or dizziness or vertigo is actually less useful than the timing and triggers approach suggested by Dr. Edlow in this monograph. We know that patients with vertigo are more likely to confirm a sensation of spinning, like on a tilt-a-whirl, but that doesn't actually confirm any particular diagnosis. So we know with vertigo there's some loss of eye control and usually nystagmus, but again, this does not confirm any particular diagnosis and is less useful than the timing and triggers approach suggested by Dr. Edlow. What are our history items? I like the OPQRSTU system. Onset. When? When did it start? Is there a history of the same or similar onset? P, provocative and palliative. In other words, does head movement make it worse? Does lying down with your eyes closed make it better? What is the quality? Is it actually lightheadedness or spinning? R, related symptoms. Are there ENT infection symptoms? Are there neurological stroke type symptoms? S, severity. Is it in general mild, moderate, or severe? T, temporal, and this is very important. Is it intermittent? Is it constant, and has it been constant for several hours and is now present in the emergency department? And are they under the care of a clinician? Do they take meds specifically for this dizziness? Next, let's consider dizziness history associated symptoms. Are there infection symptoms, ENT symptoms that might be causing irritation to any portion of the head and neck? Are there chest, GI, or GU symptoms that can be causing fever or dehydration, for example? Are there specific dehydration symptoms, nausea and vomiting, exposure to heat, poor PO intake? Are there specific stroke, posterior stroke, or TIA symptoms? Are there cardiovascular symptoms such as palpitations or apparent orthostatic symptoms due to cardiovascular meds? Is there a history of GI bleeding or anemia? Is there pregnancy a possibility such that we have to consider ectopic pregnancy? Is there a specific history of dizziness or a history of near syncope or syncope related to dizziness? Has there been a history of motor vehicle crash or trauma that could cause cervical artery dissection, either in carotid or vertebrobasilar arteries? So let's look at the dizziness history and the new approach suggested by Dr. Edlow. The ATTEST mnemonic helps us. Is it A, associated symptoms? T, what timing? T, what triggers? E, what examination findings or signs can we see? and T for confirmatory testing based on our specific dizziness exam. Now, this is the clinical pathway for the approach to ED patients with acute dizziness, and there are many parts of it that we will consider today. In conclusion, the ATTEST system for the evaluation of the dizzy patient includes the following: A, associated symptoms; T, timing and triggers; ES, examination signs; and T, confirmatory testing. ATTEST. When evaluating an ED patient with dizziness, please consider the following. Using the ATTEST system for evaluating ED dizzy patients, those patients with acute, severe, continuous symptoms should be considered to have acute vestibular syndrome. Patients who have intermittent symptoms or non-continuous symptoms at the time of evaluation are noted to either have triggered or spontaneous episodes of dizziness and vertigo. Topping the list of diagnoses using the ATTEST system are orthostasis, BPPV or benign paroxysmal positional vertigo, and posterior stroke. BPPV can be diagnosed with the Dix-Hallpike maneuver and can be treated with the Epley maneuver either in the emergency department or in follow-up. It is noted that you should evaluate patients with caution in the setting of the COVID-19 pandemic, as the COVID virus can cause neurological symptoms and/or can complicate those neurological symptoms because of poor PO intake and dehydration, which can cause orthostasis. Electronic medical record templates and dot phrases can help to make the exam process more systematic and easily accomplished using the ATTEST system. When evaluating dizziness patients in the emergency department, the following is recommended. Understand that the dizziness pathologies using the ATTEST system fall into 3 diagnostic strata and basically involve 6 diagnoses and 3 specific treatments for those diagnoses. Also recommended is that you study the Nystagmus findings, significance, and BPPV maneuvers, Hallpike and Epley, online and in the monograph from which this lecture was obtained. Also, create EMR templates and dot phrases to exclude posterior stroke findings in your dizzy patients in the emergency department. Explain the etiology of the dizziness, including the diagnosis and treatment, and provide appropriate referral for patients with dizziness, explaining to them symptoms which should cause them to come back to the emergency department for repeat evaluation. Lastly, utilize caution when evaluating dizziness patients in the emergency department in the setting of COVID-19, as this virus has both neurological complications and symptoms and can cause orthostasis due to decreased PO intake. If you have specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you to go to the fern.org website for more content related to this educational program and other content related to the care of patients who present to the emergency department with acute illness and injury related to neurological emergencies. Thank you for your participation in this FERNE educational program.